Welcome, everyone. My name's Mervyn Morgan. I'm from the ITPSA Board Association. We have the pleasure today of being joined by Dr. Will Lester. We're also hopefully going to be joined by Professor Adrian Newland as well. Will and Adrian will be on hand to answer any questions. We've also got some members of the other members of the ITPSA Board Association. Rhonda Anderson, their senior patient mentor, and she hates me saying that, but I'm going to say it anyway. Anthony Hurd, one of our volunteers who does lots of our social media, and Diane White, who also supports me in the bits I do. So before we start, has anyone got any questions they would like to ask to kick off? No, I've got one question here. It's from a gentleman called Zach Pitt, and Zach is asking, because he's new to the world of ITP, having only been diagnosed 6 weeks ago. He's asking, is there any evidence, either for or against, that the use of hot and cold therapies such as saunas, steam rooms, and ice baths to help or helps with chronic ITP? Both hot and cold therapies are generally regarded as helping to support the immune system and also help reduce stress in the general population. Does this differ for people with ITP? Will, are you going to take a stab at that one?
Yeah, will do. So there's a big thing at the moment about cold showers. And so Michael Mosley, unfortunately that medic who, came a cropper, had recommended it, and that there are other people who are saying the same, that if you take a cold shower, that there's an element of adrenaline secretion to begin with, sort of a stress response. But if you keep doing it, you don't necessarily have to have a freezing cold shower, but you can have a sort of medium, sort of slightly cold shower, that actually if you keep doing it, your body acclimatizes and you don't get the same stress response. And the knock-on effect is that you actually reduce your overall stress responses in the day. And I mean, I think most of us accept that the mind and the body are intrinsically linked. They're not a separate thing. When the mind is not great, the body's not great, and vice versa. And so if you can do something to modify your stress response, then actually it could lead to better health. So I think there probably is something in it. I mean, you could also say that the happiest nation in the world, I think they're the Finns in Finland. And, I suspect they probably do a lot of that sort of hot and cold thing.
That's very strange. I was with one of my colleagues who runs the ITP Association in Finland was actually with me at this other conference over the weekend, and she swears by it.
Yeah,
she absolutely swears by it. So yeah.
So I think there is something in it, and I think it's about it's maybe about using a tool, like semi-cold showers, to modify stress responses, and with a knock-on effect that a lot of people say we know that certain things will trigger a flare in ITP. We know a viral infection can do that, but also often people say, look, I've been really stressed out, and my ITP's definitely flared, and you don't poo-poo that, because I'm sure that's a factor. And so I think probably there is something in it, but I guess the science, it's difficult to there's no publication that I could quote saying that the hot and cold therapy improves ITP, but I'm sure it probably helps with the overall physical and mental stress response.
I must admit, I haven't seen any scientific evidence on it at all, but people do claim it helps. So it's what happens up here as well, isn't it?
I think there's some plausibility to it, I think.
Yeah, good. Rhonda, you got a question?
Yes, well, people do that wild swimming, don't they? Which is really, really cold. And there are people who jump into Serpentine and various other places. They break the ice first and then they go in for a swim, which sounds absolutely horrendous to me. But I was just wondering, Mervyn, if your Finnish colleague is somebody who was doing that before they had ITP, or are they only doing it after they got ITP?
I suspect, knowing her as I do and knowing many people from Finland as I do, she was doing it well before. So,
yeah. So it didn't stop her from getting ITP.
It didn't stop her. No. But
I think you have to be really careful. I mean, I appreciate everything that Will has said, but I think that really I would really want to know some scientific evidence for it, really, and perhaps it is out there, and perhaps we just need to find it.
Yeah, as Will said, they are a very happy people, and she's a very happy person. So,
but she's still got ITP.
She's still got ITP.
I think the wild swimming thing is probably similar to the cold shower thing. You know, it's about sudden cold exposure. But they do say that don't just immediately get into a cold shower. You should probably just turn down the heat a bit, have a sort of semi-cold shower. And actually, when you first do it, it does generate quite a stress response. But if you keep doing it, you potentially get the benefits. And even if it doesn't help with the ITP, it might actually, help with general well-being.
Yes, that's true. That's true.
Yeah. I was just wondering, Les, Will, if this isn't too much of a personal question, do you do cold showers?
I'm thinking about it. Michael Mosley did this just one thing, and so I've tried a couple of them actually. Just out of curiosity.
Well, I've got an article that will be coming up in the Platelet. I only sent it to Mervyn today. It's a tribute to Michael Mosley. I love Michael Mosley. It's such a sad thing that he died, isn't it?
Okay, Trevor, you got a question, sir? You better unmute. That's it.
Yeah. So in regards to the cold thing, I wasn't going to say anything, but I think it might be relevant. When I wasn't diagnosed with ITP first. I was diagnosed in 2010 with cold autoimmune hemolytic anemia, and if I got cold, that was the trigger for me getting the hemolytic anemia. And it was only about a year later that I then got ITP. And my consultant said it's unusual that you should get one thing and then sometime later get another. And I'm just wondering about the whole cold thing, because this was flagged up when I was first diagnosed with the anemia, that, the cold, if I got cold, that would trigger it all off again. So I'm just wondering if there's a link in regards to that.
I can answer that. So the first thing to say is you should definitely not have cold showers.
No.
It's quite rare. It's a rare condition, cold, autoimmune hemolytic anemia. And there's another condition called CHAD, which is cold hemagglutinin disease, and they are autoimmune conditions like ITP. So it's where you form an antibody that, instead of doing a good thing, which is fighting infection, it's doing a sort of bit of a bad thing, which is attacking your own cells. The cold thing is that some antibodies work better in the cold than in the warm. The commoner type of anemia is the warm hemolytic anemia, but it's well described that some individuals get both the hemolytic anemia, so that's destruction of red cells, and ITP, which is destruction of platelets, and that's called Evans syndrome. So Evans basically described this idea that you can get more than one antibody that attacks more than one blood cell, and also that you can also attack your white blood cells, so you could attack your neutrophils, and actually Evans did describe that as well, that some people have low white blood cell counts and low platelets, so you can have a combo basically of ITP with either an additional antibody attacking white cells and additional antibody attacking red cells, and then it becomes Evans syndrome. And so I guess you probably fall into that bracket. It's important because response to treatments in Evans is a little bit different than in ITP that's isolated, ITP on its own. So for example, we know that splenectomy, so we don't do this very often anymore, but removing the spleen is less effective in Evans syndrome. Rituximab, we do use rituximab a lot for ITP, but it maybe has a slightly lower chance of working in Evans syndrome. So I don't think it's the cold that caused your problem, but your problem is made worse by the cold. But yes, unfortunately, sometimes autoimmune conditions hunt in packs. You know, you don't just get one, you can get more than one. And it probably reflects the fact that that in modern society, we live in it, despite all the sewage that's getting pumped into all the rivers, we live in a relatively clean environment. And one of the concepts is that because we live in a clean environment, our immune systems are sort of idle. You know, we're not fighting off parasitic worms and other infections all the time. But genetically, some of us are more susceptible to developing autoimmunity when our immune systems are idle. The immune system is a powerful weapon and it fights infection, but when it's not fighting infection, it can misbehave, and it can misbehave in more than one way, basically. So it's not uncommon for families to have multiple different autoimmune problems, thyroid problems, joint problems, ITP, other autoimmune conditions that, you know, they can hunt in packs, and some of it's genetic and some of it relates to our sort of clean environment that we live in now.
Okay, thank you, Trevor. Does that answer your question? Yeah.
Yeah, it's revealed quite a lot actually, because at the moment I got COVID about 3 months ago, and my platelets dropped down to 1, and I'm being treated at the moment in a new health authority because I moved house, and I'm in a completely different place to what I have been before, in that I've been on Eltrombopag, prednisolone, dextromethasone, and the next course is romiplostin. In the past, I've been straight on to rituximab. So what you were saying, Will, about the rituximab was really quite interesting, because it's the one thing which has pulled me right up to almost normal levels.
Yeah, I mean, rituximab still can work even in the Evans syndrome, but it's slightly different than if you've got a pure single problem. It works. Rituximab works really well actually for the autoimmune hemolysis. So for antibodies against red cells, which is what you had, you know, it does work quite well. For ITP, it's about a 50% response rate, but for hemolysis, for the red cell destruction, it's actually better than 50%. But it's interesting what you said about the COVID. So people have looked at how COVID has caused exacerbations of people's ITP. So, you know, you've got ITP already, and then you get the infection. You know, what's the chance that it's going to make it worse? There's a reasonable chance that for a proportion of people, it will cause a sort of either a relapse or an exacerbation. So viral infections do that. Sometimes the vaccinations that we get can do that as well. Anything that slightly disrupts the immune system can cause it, sort of trigger a exacerbation. And what we found was that for COVID-related exacerbations, that you mentioned drugs, Eltrombopag and romiplostin, those drugs were quite good for getting people out of a pickle when they got an exacerbation. But even standard therapies like steroids can work as well.
Okay, thank you very much. And I've just noticed Zach Pitt, the chap who sent me the question in about the hot and cold saunas, joined halfway through that question. But Zach, never fear, I've recorded it, so you will be able to see how that panned out about the hot and cold showers, should you, shouldn't you?
Yeah, we're not going to do another 10 minutes.
We're not going to do another one on that. No. Right.
It's one of the best questions ever, really, because it really triggered a lot of interest, didn't it?
Great stuff. Right. Patricia, Hi, Patricia, you got your hand up.
Yeah, excuse my voice because I caught a cold on an aeroplane, which was freezing cold. But I'm in America at the moment, and I won't be back for 2 weeks. But this is what happened to me. I've had ITP for like 13, 14 years. And I started off with cortisone and then IVIG. And then after lockdown, they put me on Revelade. So I've been on Revelade for 3 years. And I usually go to the doctor at the cancer clinic in Chichester. Now, the last few months, they've changed it that we see a hematologist instead of the physician. Now, what happened beginning of April, I started in the jaw actually, but I started getting terrible pains in, let's say, the left limb, and it got worse at night. About 8 o'clock every evening, it would really start, but then it'd be better the next day. Then the next night, it might be the back of my knees, and then that would be better the next day. The next day, it would be my right shoulder and arm, and the pain was absolutely excruciating at night, and no pain pills would do any good. Now, the hematologist, 2 months ago, I said to him, could it by any chance be the Revelade that's causing this? And he was angry with me, and he said, I'm taking up his time because my platelets are fine, they're within normal limits. And I said, yes, but usually my platelets about 80 or 90. And one hematologist said it's good just to keep it below 100. Anyway, this hematologist is really angry with me. And I tried to explain to him why had my platelets gone up to 360, because that's so abnormal. Anyway, he was angry at me, and he said he didn't care about my pain. So I asked my physician, she went onto the web and saw that there were side effects of Revelade. So she wrote a little note. So when I went back to the hematologist again, he went on the same old thing. I was taking up his time. He had lots of patients, and it's nothing to do with the Revelade, and he doesn't care about my pain. And I said, well, I'm going to America. Could I have at least a prescription for a prednisone type of medicine? Because when I went into the hospital the first time, they gave me prednisone the first night, and then I was better the next day, but they said they can't continue that because it softens the bones. And so I said to the hematologist, can't you sign it? He said, I'm not a doctor. And I said, well, do we have a doctor here? He said, you don't have a doctor here. I said, oh, yes, I do. I have Dr. Wilson. So we rushed into Dr. Wilson's office. Dr. Wilson came back. He said, take her off immediately. And he gave me a prescription to get to America. And after about 3 weeks, my pain was much better. I wasn't getting this terrible pain at night. I did have some pain. I have a little residual. So I'm watching my platelets. They were down to like 100 and I think it was 157. So I'm watching the platelets because I go to a doctor here who knows about ITP. Now, the
doctor in the
doctor
UK
has given
was
me
this,
this.
Pat? Which hospital was this in the UK?
St. Richard's in England.
Yeah.
But here it's Aurora Hospital. They
Okay.
put me in Aurora Hospital here for 5 days.
Yeah, yeah.
And they couldn't find anything wrong with me at all.
Was the consultant back in the UK aware that you are a nurse?
In Wisconsin, I'm in Port Washington.
No, no,
Is
no.
that
Was
what
the
you asked?
consultant in the UK aware that you are or were a nurse? You were a healthcare professional yourself.
Well, St. Richard's in Chichester and the professional Dr. Wilson
Okay.
is a cancer group.
Okay.
And I've been going there for years and they've been marvellous. This is the first time.
So your question is really like, couldn't that drug they gave you cause them side effects, isn't it? Yeah.
Well, yeah, because since Dr. Wilson's taken me off, then the side effects started disappearing, but it took about 3 weeks.
Okay.
And I was over
Would
here.
that be normal, Will?
Am I answering your question?
Nearly. Will, would that be
Yeah, I
normal?
mean, I think that there's a number of sort of issues here, and one of them relates to, whether a particular site, you get a particular symptom, and is that related to the drug? And it can be really, really difficult to know. Sometimes, it's not a typical side effect. We wouldn't classically expect flitting pains in different parts of the body to be related to a drug like Eltrombopag. But sometimes people have unusual reactions. We have to keep an open mind. And rarely, when we're really, really not certain whether a particular drug is causing a particular reaction, we have to think about switching it to something else, because that's the only way to know for certain, is to get someone. But it's really important, I think, for people here that are listening, is that if you're on this class of drugs, so this is called a TPO receptor agonist, TPO-RA. So there's Eltrombopag, Revelade, Romiplostim, that's Nplate, and Avatrombopag, Doplet, that you don't just suddenly stop them, ideally, because if you stop those drugs abruptly, there's a very big risk of a sudden crash in the platelets. So it's always better with that class of drug to wean it. If you're going to try and change it, to wean it, or either switch it to an alternative drug that will accommodate. But a sudden abrupt stop can be risky. But yeah, sometimes it's not clear. I prescribe a lot of different drugs, and people have side effects, and they may not be typical side effects, but occasionally we go down that route of saying, okay, we'll try something different. There's another issue here, which is perhaps a breakdown in a relationship between the sort of patient and the physician. And you always have a right to ask for a second opinion. That's a very reasonable thing. If you feel that your relationship with a clinician is not healthy, then you can ask to see someone else, either in the same hospital or in a different hospital. I think when someone's care is really complex, you can ask to be referred to a specialist centre. So there are lots of issues that have been brought up here, and I can't answer all of your questions. And whether those flitting pains relate to the Eltrombopag, it's difficult to say for certain. There are very specific pains that you can get with these drugs, these TPO receptor agonists. One of them is sort of burning and pain in the peripheries, so the tips of the fingers, the tips of the toes. If you get that probably is related to the drug, and that can be related to sort of the platelets being a little bit sticky. But flitting pains like this, it's difficult to be sure, really.
Okay.
I
Does that
suppose
answer
to
your
see a
question,
neurologist.
Patricia, does that answer your question?
I was supposed to have seen a neurologist, but it never happened in England. I went into hospital here for about 5 days, and they tested me, my brain, everything, MRIs and things, and they found not anything wrong with me.
Okay. Thanks, Patricia. Thanks. We'll have a chat afterwards. Right. Who else has got a question?
There's some in chat, actually.
Is there? Right. Let's have a quick look. Just having a quick look now.
Yeah, we got someone with a good positive response to rituximab. That's good.
Yeah. Oh, yeah. Ria.
Yeah. So overall, I say there's about a 50% overall response rate. And then after about 5 years after the rituximab, about 20% of people are still in full remission. So it's a good drug in the sense that you just give maybe 4 doses. And if you're one of the lucky ones and you get a response, then great, because you can come off therapies.
Yeah.
But
And I
we
see,
can't predict actually who is going to respond and who
no,
isn't,
no.
unfortunately.
I see Ria also mentioned that she did have a relapse, and then she went on MMF, which
Yeah.
Anthony, that's what you was on, wasn't it, or are on?
Yes, that's exactly what happened to me. I had rituximab in 2010 and 2013, and it did very well for me. I went completely into remission for about 2.5 years, with no other issues at all, no other problems. But then I relapsed in 2016, which was not unpredictable. We predicted it might happen, to be honest. And since then, I've been on mycophenolate mofetil, MMF, successfully with normal platelet count, barring the odd blip here and there.
Yeah.
But yeah, very, very, very happy with that. Thanks.
Good stuff. Ria, you got your hand up there.
Yeah, I just wanted to add, I had rituximab. I got diagnosed with ITP in 2017, and I got diagnosed with antiphospholipid syndrome this year as well. I'm just wondering, Will, if you were one of these specialists that I've come across on Apps UK, do you specialise in that as well?
Yeah, so there's a list of us clinicians with an interest in APS that are listed on the APS website. And actually, APS and ITP, they're not, that there is a link, so that if you have ITP, you're a little bit more likely to be diagnosed with APS and vice versa. So there is a bit of a crossover here with ITP and APS. The ITP you get with APS is a little bit different than the ITP you get without APS. In that actually rituximab is a really good drug, and actually bleeding is slightly less of a problem with APS ITP, but thrombosis is more of a problem.
Yeah.
We often talk about ITP being a bleeding disorder, but there's a flip side of thrombosis, and that's particularly the case in APS.
Yeah, that's what I've been struggling to get my head around, how they're so complete opposite.
Yeah, it is complicated. And yeah, ITP anyone with ITP actually has a slightly higher risk of thrombosis than someone with ITP, and that doesn't make sense, because you think, well, if I've got low platelets, surely it's a bleeding problem because your platelets help you to clot, and if you've not got platelets, how can you clot? But it's not that simple.
Yeah.
But yeah, with APS, it's definitely more of an issue, and rituximab is a really good drug. And I don't know if you're on anticoagulants, but if you need a blood thinner, you need to keep, if you need a blood thinner because you've had a thrombosis, be that aspirin or an anticoagulant like warfarin or one of the related drugs, you need to have a good platelet count. You need a platelet count over 50. So you have to get the platelet count above 50 to safely be able to give the blood thinner. So you're sort of trying to, get the balance right.
Yeah, okay. I have been referred to someone in St. Thomas as well, because I'm 23 and I had bilateral PEs last year. So.
Yeah, I mean, Thomas's is a sort of a key national centre for this sort of thing. So yeah, it's a good place to be reviewed, actually. Yeah.
Thank you for answering.
Thank you, Ria. There's a question from Sue about herbal products and food, which are advertised to boost the immune system. Would they also cause the body to fight platelets or fight the platelets?
Yeah.
So,
I mean, this is, if I was to say, what is the commonest thing that I get asked as a clinician seeing people with ITP, it's about what can I do with my diet to improve my ITP. And it's the hardest question to answer. It's the commonest question to get, and it's the hardest question to answer. I think this, we can give easy advice like have a healthy diet, fruit and vegetables, eat healthily, because that's good for your physical health, and that can't be a bad thing. But when it comes to specific foods, it's really complex, because we don't really understand whether some foods can exacerbate things, some foods can help things. I mean, it's an area that's just, we don't know. And ITP is not one condition. ITP is complex. there's variation between individuals. You know, one person's ITP is different than another person, so you can't give a blanket advice really about this. There are certain, I mean, this is a rare thing, but there are certain drugs that can trigger that can cause a low platelet count, and one of them is quinine. But it's very rare. But there is a quinine-associated problem with platelets. So, and quinine is in some types of tonic water and not in other types. But that's incredibly rare. So I guess there's a very small subsection of people who probably should avoid quinine, but we really, this is an area that is not well understood. So often you'll get the advice you'll get from us as clinicians is eat healthily, but we can't really tell you any more than that. And I wish I could, because what we all want to do is control. We want to control our life. We want to control our conditions. And what we eat is one thing we have control over. And it would be great to be able to give people a pathway to control, you know, using diet. But we hand on heart, it's very difficult to do that. But it's a great question. And I wish we would, it's an area that would be really interesting for research, actually.
Yeah.
But it's complex.
Yeah. That question actually came up in America at the conference I was at recently, and you know what it's like in America, that they're advertising all this stuff that can, you take this, it'll boost your immune system, your platelets, etc. And every healthcare professional who spoke debunked the lot. Yeah, there wasn't any science behind it at all. So,
I mean, they invented snake oil, didn't they, in the States? I'm sure.
Yeah. And I believe it's Professor David Cooter's got a famous slide that he uses up about this 1880 blood purifier, and he says he's been trying to find a bottle for 100 years, and he's never found one yet. But anyway,
I mean, as a rule of thumb, if anyone asks you for a lot of money for a supplement, then
don't go near it.
Don't go down that route, because they're interested in one thing, and that's getting your cash.
Yeah. Rhonda, you got your hand up.
We have previously had this question many times on the Zoom, and we have explored it extensively. And I think the answer is that, just like you were saying, Will, we don't know. If you find something that upsets you generally that you eat, whether you've got ITP or not, you'd be mad to keep on eating it. If strawberries make you sick or bring you up in itches or whatever, you just avoid strawberries. And that's easy enough. But there is nothing in the research that we have done, there is nothing to say that anything that you eat or rub on your skin or anything else is going to cure your ITP or improve your ITP. But what, Les is all, sorry, I keep calling you Les because it looks like Les on your screen. What Will has said is that, just have a healthy lifestyle. And that is one of the things that we promote, and I promote in my column in the platelet. And there are plenty of back articles that are on this issue. And we can only talk about health and well-being in general terms and not specifically. And every single person is an individual. So something that might irritate you or upset you or change your body chemistry is going to be different for some other person. And it also really, really important, we've touched on it earlier today, is about stress. Stress and doing all the sort of so-called right things for your health and well-being, like being a healthy weight, getting exercise if you're able to, hydrating yourself, eating sensible food and not rubbish and, all that kind of stuff. So, I mean, there's an enormous thing now about processed food. So, I mean, if you can get the books on it and look at that, and you might decide to reduce or eliminate processed food from your diet. And, all I can say about that is that would probably be a very good thing. But it's very, very difficult to eliminate processed food from your diet because everything you look at has got something, has had something done to it.
Yeah.
But anyway, that's just a general answer because, you know, we're aware of it.
Okay, thank you. Thank you.
There is a really good, there's a good, I think it's very much related to this, but there's a good comment actually from Sue Habgood saying that your gut is closely linked to your brain. I'm fascinated by the connection. So one of a really interesting area is the microbiome. So this is your gut bacteria, and it's a big organ of your body. You know, it's many kilograms of your what makes you who you are. And your microbiome is variable, as in it can change depending on what you eat and drink. And you know, there's been some interesting work looking at whether the link between your microbiome and illness. And there's some interesting work on, we talked about a little bit earlier about this thing called antiphospholipid syndrome and ITP. There's some interesting work on antiphospholipid syndrome, and that maybe there are links between your microbiome and your risks of developing certain diseases. So we know that it probably is important, but what we don't know is how you modify your microbiome to improve your health. So it's an area of interest, but it probably is really important. You know, what's sitting in your gut has an influence over your overall physical health. But it's an area that, yeah, a fascinating area, but we don't know how best to manage it.
Okay, thanks, Will. There's a couple of questions on here as well about Eltrombopag. One from Sue again. Interested to know, because she's been advised that she may need Eltrombopag, and she's interested to know how it works and what the benefits and are there any downsides. Yeah. And then there is another one from Sue. Another Sue, are there any issues with long-term use of Eltrombopag? I recently lowered my dose to 25 milligrams daily, and my platelets are around 50 to 80. So I've been on it since 2020, but with only mild side effects. So is there a platelet level that's considered as in remission?
Yeah, so lots of different questions. So Eltrombopag is this class of drug, the TPO-RAs. There are 3 that are available in the UK. Eltrombopag, avatrombopag, romiplostim, 2 orals, 1 injectable. They work in the same way. So they basically they mimic a natural body hormone called thrombopoietin. Thrombopoietin is made in the liver, and it travels to the bone marrow, and it sends a signal to platelet-making cells in the bone marrow called megakaryocytes. These huge cells in the bone marrow, and they make platelets, millions and billions of platelets every day. And so by taking these drugs, you're basically mimicking a natural signal and telling your megakaryocytes to make more platelets. And in terms of long-term complications, so there are a lot of people who have been on these drugs for many, many years, decades even. And most people do not have long-term complications. Very occasionally, the stimulation of the megakaryocytes in the bone marrow can cause some fibrosis, some scarring in the marrow. It's not very common. If we see it and we stop the drug, it gets better. So in terms of long-term complications, you know, not common. Remission, it would be considered to be a normal platelet count. If you're running a platelet count between 50 and 80, that is what we call a partial remission. So that's fine. You know, a partial remission is fine. When you give these drugs, it's reasonable to say, what is the lowest dose of this drug I can get away with to give me a safe platelet count? You know, you don't have to have a normal platelet count. A platelet count over 50 is pretty good for pretty much anything. If you need a brain surgery, you probably need a platelet count over 100, but for anything else, over 50 is good. So it's reasonable to take the lowest dose you need to get the platelet count that looks after you, basically. So you don't have to have full remission. Partial remission is fine. And generally speaking, these drugs are safe in the long term. There's no new complications that we've become aware of in the last decade from this class of drugs. And there's another bit about flu and COVID. Yeah, dose of COVID steroids. Yeah, so when COVID first hit us, if you think about how we treat ITP, so ITP is a condition, an autoimmune condition where you're making, let's call them bad antibodies against platelets instead of good antibodies that fight infection. And so the mainstay of treatment for ITP has been immune suppression, trying to calm down, bring down these bad antibodies. These drugs like Eltrombopag, Avatrombopag, and romplostim, they don't suppress the immune system. They just trigger more platelet production in the marrow. So when we first hit COVID, we felt that maybe it was better to use drugs that don't suppress the immune system because we don't want to impair people's ability to fight COVID. So we got temporary permission from NHS England to use drugs like Eltrombopag up front because we knew that we wouldn't impair people's immune systems and that they, would not impair their ability to fight COVID. So we use those drugs specifically in that context. But now COVID has become, it's not nice to get it, but it's not the disease it was. And so we've moved away from using these drugs up front, and we're quite happy to use immune suppressing drugs, just like we always have done. Mycophenolate we've talked about, it's a great drug, works well for some people. But yeah, we're less worried about COVID now. We don't feel that if your immune system's suppressed that you're going to come a cropper with COVID anymore. So there was a lot of usage, especially early on.
Okay, thank you, Will. I hope that helps, that question. We've had a couple of questions on here about fatigue and ITP. Now, this brings me up 2 weeks ago. I had a phone call from one of our members who had just been diagnosed with ITP and had been to her hospital. I won't name the hospital, but she has spoken to her consultant complaining that she was experiencing extreme fatigue. The consultant told her basically to go away. Fatigue is nothing to do with ITP, which is one of the worst answers I've ever heard. Anyway, education's on the way there. I've found out who it is, so he's been sent a pack of stuff. But as many of people who studied ITP know, fatigue is one of the top symptoms that all patients identify, and it's also there's one on here, a young child, terrible fatigue, 12 years old, when the count is below 20. Now, I've heard of patients whose count is around 40 or 50, if not more, who still experience fatigue. Yeah, do you have the same?
Yeah, absolutely. It's really complex, and for some people, if you get their platelet count up, their fatigue improves. For other people, not so much. If you see a clinician and you've got ITP and you talk about fatigue and they say fatigue isn't linked with ITP, you're not seeing the right clinician. Anyone who keeps up to date with ITP and manages people with ITP should very much appreciate that fatigue is a key symptom. We have a study called the IWISH study.
Yeah.
It's often quoted, many of you will be familiar with it. And, fatigue, in terms of its impact on quality of life, fatigue scores as highly as bleeding. You think, well, ITP, low platelets, bleeding, that's the problem. Fatigue is at least as important as the bleeding side of things. One of the questions is why. So, you've got a condition where your immune system is attacking your platelets. Is that a problem? Your immune system's hyperactive. It's attacking your platelets. Is that draining you of energy? I mean, the most recent study was looking at people who present initially with very low platelet counts. Often with ITP, your first presentation, your platelet count is really low. If you do very detailed scans in people with very low platelets at presentation of their brains, you can see tiny, tiny little bleeds. Not bleeds that cause harm, but tiny, tiny bleeds. And one of the research questions was, are these tiny, tiny bleeds in the brain one of the factors causing fatigue? Is it a physical brain problem? and they looked at people who had these tiny bleeds and those who hadn't, and there was no link between fatigue, and some of the other symptoms that people can get, sort of cognitive problems, poor memory, brain fog, all of those things that often go together. So we can't fully explain these symptoms, but it's not related to these tiny bleeds that some people get. So that's the hot off the press that was presented at the ISTH in Bangkok this year. So it's not a physical brain damage thing, it's something else. But it is common, and it's not just fatigue, I say brain fog, memory recall issues. It's a more global problem, and it's it probably does differ between individuals. It's probably not just one problem.
Okay, thanks, Will. I will mention there as well the IWish survey. That's IWish 1.0. Now, we're actually working on at the moment a number of abstracts for the results for IWish 2. So some are out already, but others will be out. But what I would do when I publish the video of this meeting on YouTube, probably tomorrow, I will put the link to the abstract that we did that was published for IWish 1 that highlights the fatigue issue as well, so you can read it. Okay, so right.
Mervyn, I think it's worth mentioning that in the results of the patient perception survey.
Yeah, I was just going to say that next. Our patient perception survey, Diane's just been collating all the results for me, and we pulled it together. And once again, fatigue is way up there. Top or 1 or 2, I think it was.
Well, I think the main point here, actually, in what we took perspective, what we're talking about, is that really the results came through that the fatigue doesn't ease off, and perceptibly until you get over 100 count. And it's quite interesting what Will was saying about these minor bleeds, because that really demonstrates what the brain fog is. I mean, for myself, I think I've improved my quality of life by improving my gut, in so much as I seem to have kept my platelet counts fairly stable on romiplostin for a long time. But I've just been through a house move, and my platelets have dropped like a stone.
That's again, yeah.
And I've had terrible brain fog on a few days. So, it just shows what a difference all these things can make.
Interesting point on there. There's about 3 people in the chat have said they was initially told fatigue wasn't a symptom of ITP. So it's a shame. It's a shame.
Yeah, I mean, as hematologists, I suppose to defend us, we have a multitude of different conditions to look after, and I think everyone deserves to see someone who has developed some expertise in their condition, and not every hematologist is going to be able to have the bandwidth to be able to provide that expertise, because they may be an expert in some other conditions, but they can't be expert in everything.
No, that's true.
So you don't have to go to a specialist centre. You don't have to go to St. Thomas's. You don't have to go to a super specialist centre. But I think you deserve to be seen by someone in that centre who has taken it upon themselves to be up to date in that condition. So that's what tends to happen in hospitals, is that some people will specialise in one thing, some will specialise in another, and you do deserve to be seen by someone who's taken it upon themselves to be up to date in that condition. And ITP is not something that anyone can just dabble in. You wouldn't, if you had a specialist type of leukemia, you wouldn't expect someone to look after you who didn't have much knowledge about that leukemia. And it's the same with ITP.
Absolutely. Right, Lauren, nice to see you.
Hi, good to see you too.
How's Cumbria? Okay.
It's sunny and warm, so that's good.
Okay, you got a question?
Yeah, this wasn't my question actually, but just following on from what Will said, I really appreciate that. I guess asking, what is your advice for those of us in more rural areas, smaller centers that are seeing hematologists but may not have been with an interest or in an ITP?
Yeah, I mean, ideally, if your case is particularly complicated, that there would be some way that a person who's not a sort of full-on specialist would be able to then draw from whoever, you know, their local specialist is. And, you know, you could have someone in a small, what we call a district general hospital, who does keep up to date with ITP, that's fine. But I think if someone suggests that they're not, then I think it's perfectly reasonable to ask to be referred. You know, it really differs between, there's no one size fits all here, but everyone deserves to be seen by someone who's keeping up to date with that particular condition. And they don't necessarily even have to, you don't necessarily even have to totally transfer care. There can be what we call shared care. I give advice to multiple hematologists across a population of 5 million people, where patients are perfectly happy to have their local care, but they do get some specialist input as well. So there's lots of different models. But there are there are markers where it's not ideal. One of them is if someone keeps you on high doses of steroids for a long time, that suggests there's a problem, because that's not what you should do. And another one is where, you know, you bring up your symptoms like fatigue and you get told that's, you know, not an issue, then that is also a sort of, rings the alarm bells. But it doesn't mean you can't be looked after in your own local hospital. And people will generally, you know, try and divvy up their special interests in most hospitals now. You know, someone will take a special interest in one thing, someone will take a special interest in another.
Okay.
Thank you, Will.
So can I ask?
Was that your main question or not?
No,
question?
Yeah. It's a quick one, hopefully. My main question, I'm going to be starting on a targeted biological therapy for another autoimmune disease. And I just wondered if you had experience with ITP patients on a...
Yeah, so these are the disease-modifying drugs, the biologicals. You know, we often find, and I mentioned a lot earlier that autoimmune conditions can hunt in packs. You know, you can get multiple autoimmune problems at the same time, you know, both individually and in families. And we often find that these biologicals do sort of help, actually. You know, if you give a immune treatment to one autoimmune condition, sometimes the other ones benefit from that as well. There's a lot of crossover. You know, rituximab we've talked about, you can use that for multiple different autoimmune problems, and you give it for one of the problems, it helps the other. So yeah, my experience has been biologicals generally make things better rather than worse, but you know, there's always exceptions.
Okay. Thank you.
I don't know if that's your experience, but
we'll see.
Thank you, Lauren. Thank you. Right, there's a couple more in the chat. I'm just going through them now.
There's quite a good comment saying hematologists admit they don't know rather than ITP.
Yeah, Sue. Yeah, well done, Sue.
It is actually, it's very hard for us to admit when we don't know something. And sometimes the response to not knowing something comes across as being quite aggressive. You know, you find that often with clinicians that they feel that they've got to instill confidence, and therefore when they feel uncertain or challenged, that sometimes the response appears aggressive. But actually it's a reflection of someone's lack of confidence. We're only humans.
Well, we're all human. We're all human.
Yeah.
And just want to point out something else Sue Hadgood put on. She's mentioned the document, which I believe will be the ITP discussion guide that she used to help prepare her for her consultation. She said it worked, which is good. You know, that is good to hear. We got this document that we produced along with the ITP Clinical Forum with Quinton. And it's a series of questions that people can complete, and it guides them into what questions they need to ask their consultant, you know, when they have their their appointment. So it's really good to hear that that's worked. Another one, I have ITP, but also have a hiatus hernia. So would that contribute to my count going up or down regularly?
I mean, it shouldn't really contribute to the platelet problem. There is, in terms of stomach conditions, there was a lot of interest in H. pylori.
Yes.
So this is a bug that you can get in your stomach that can cause stomach ulcers. And they found in Japan that if they treated this stomach bug, the H. pylori, that people's ITP got better, but we've never really shown that outside of Japan. So that's a slightly different thing than a hiatus hernia, but yeah, there shouldn't be a direct link. We look for associations, don't we? We look for explanations as to why, but some of them are more plausible than others, but probably not hiatus hernia. I see there's actually earlier on, there's a few questions about young children.
Yes, there is. Yes.
Yeah, I mean, the sleep. Yeah, okay. One question is about. I was just looking at one about sleeping. I mean, people often. It's interesting with ITP. People often, before you get the actual bleeding symptoms, before you get the bruising or the petechiae, these are the little red dots you get on the skin. Often people will say, it's easy with adults so they can explain rather than children. They know when their platelet count is going down because of symptoms that are not bleeding, feeling a certain way, fatigue, that sort of thing. So often there are certain tells that someone's got a low platelet count, even without bleeding. I'm not aware, typically not necessarily a sleeping issue, but I guess if you see that as a consistent thing, then maybe it is a link.
Yeah, well, that was from Natalie about a 3-year-old. So
yeah,
she's noticed that issue, and she believes that.
I mean, you have to keep an open mind, and if it keeps happening, I guess it reinforces that maybe it is an early tell that there's a platelet problem.
Yeah.
I mean,
I'm conscious of the time as well. So
I might just mention one thing. There's another one saying that their 2-year-old daughter's diagnosed with ITP. So I think it's a little, when someone who's very young is found to have a low platelet count, it's really important to make sure that it is not something else. So we know that if we look at adults who have been diagnosed with long-term ITP, maybe around 10% or more of them actually don't have ITP. They have an inherited genetic low platelet count. And we always have to be really careful that we're not labeling someone as having ITP is where the immune system destroys the platelets. But there are other causes of low platelets. So there's a mention there about a bone marrow investigation. It's much more common for us to do bone marrow tests in young children with low platelets because we're especially conscious of the fact that we need to be sure that it's ITP. There is no test that proves someone has ITP. We have tests that rule out other causes. If we rule out all the other causes of a low platelet count, ITP becomes the main diagnosis, but there is no ITP test. So we have to be really careful, especially with younger children. Anyone who's had low platelets all their life, always we keep an open mind and say, is this really ITP or is it a platelet bomb? And we now have in the NHS a new test available that screens multiple genes. Many of them are platelet genes. It's just a simple blood test, and it's much easier now to pick up inherited platelet disorders. And we can make the diagnosis within 6 weeks of the test if needs be.
Oh, that's good news. Thank you, Will. Rhonda?
Just about the probiotics, just to say, first of all, I've had a splenectomy and I do have a lot of gut problems and I have candida in my gut, which is rather unfortunate. And I went to my pharmacist and said to him, could I have probiotics? And he said, well, I'll find out for you. And he went to the manufacturer and asked them, because he knows all my medical history, because, I'm very close to him. And he told them all my medical history, and they said no, that I should not take probiotics.
Oh. Any comment on that, Will?
I mean, my feeling is that as long as someone's not doing something that's going to cause them harm, I'm more than happy for them to experiment. You know, if someone says, "Shall I spend a whole fortune on this snake oil that someone's trying to sell me?" I'll go no. But if it's, you know, someone wants to take some turmeric, it's not going to cause you any harm. You know, so I'm a bit more liberal about these things.
Okay, thanks. Right, last question, Sinead.
Hello.
Hiya.
Can I just ask some advice? My son's 5. He's had ITP for 2 years, but has not at all to any treatment so far. So his platelet count is always below 10. We've not even had a partial response to anything. So we're just trying to think about next step with our consultant. So he's had Eltrombopag, he's had MMF, he's had rituximab, and he's had rhomboplostim as well.
Have they done the genetics?
We've had bone marrow tests.
Yeah, I mean, certainly genetics is definitely worthwhile. We always say that with ITP, no treatment is a good treatment. And, you know, if someone's not bleeding, then don't treat the numbers. Treat the symptoms, not the numbers. So you can have a numerical platelet count less than 10. And if you're not bleeding, you don't necessarily have to rush in with therapies. It sounds like they are trying therapies.
Yeah.
But the more therapies that are tried and don't work, the more we have to question ourselves about whether we got the right diagnosis.
Okay.
So, I mean, are you going to sort of a big tertiary hospital or?
He's a great
Great
Ormond Street. Yeah. So, I mean, you know, those guys will have, yeah, they'll do everything. Yeah. But the main thing is, you know, don't get overly worried about the numbers if the symptoms aren't too bad.
Okay. Thank you.
Okay, thank you, Sinead. Right, so thank you, everyone. If anyone's got any other questions, if you just want to email them to me, and I will endeavour to get the answers. But I'd just like to thank Dr. Lester for answering all the questions. We've had some interesting ones tonight, and we've had a good crowd on, so excellent. Thank you, everyone. I will endeavour to get the recording of this up on our YouTube channel by tomorrow lunchtime-ish. You may want to go on there. We've got, I think, about 120 videos on there now. We've got all the previous meetings that we've done on this. And next meeting, forgive me, I can't remember the date, will be the Scotland meeting with Dr. Catherine Baggett. That will be next month. But thank you, everyone. Take care, and